The management following a failed stabilisation procedure can be challenging. Every patient needs to be treated on their individual merits, and there are several treatment options. A bone block procedure may be indicated for bone loss, soft tissue deficiency, or a failed bone block procedure. When undertaking a revision bone block procedure, an important consideration is retained glenoid metalwork, particularly if they're broken screw shafts or multiple metal anchors, as these are difficult to extract without significantly compromising the inferior glenoid bone stock. Traditionally, the bone block has been held by screws, but these are often of a larger diameter and the position may be compromised with metalwork present. More recently, suture-button fixation has been introduced, which only requires a 2.9mm drill hole. An additional benefit of the suture-button system is it uses a jigged posterior drill guide. By identifying the retained metalwork position on a coronal CT scan, we've devised a way of predetermining a safe drill trajectory. From this we can calculate the jig position, which will avoid existing metalwork. We take the most anterior CT coronal cut to identify the position of the metalwork. The offset of the guide is 5mm, which we measure from the medial edge of the articular surface and drop a vertical line. The diameter of the drill guides are 2.9mm. We identify a position for the superior drill hole. We measure 10mm down from that, which is a gap between the drill holes, where an inferior drill hole can be positioned safely. Bisecting this line will be the position that the tip of the drill guide needs to be. We position a horizontal line at the inferior tip of the glenoid and then measure the distance between this and the position for the drill guide. We now know that the optimal position for the drill guide is 9mm superior to the inferior edge of the glenoid. We report the results of a consecutive series of patients who'd had a failed stabilisation procedure with significant retained glenoid metalwork. We undertook a revision bone block procedure using a double suture button technique, using a drill guide position that we pre-calculated from a pre-operative CT scan. We used the suture-button instrumentation from Smith & Nephew. We undertook an Eden-Hibernate both open and arthroscopically using the technique described by Taverna, but we used iliac crest graft. And we undertook a coracoid transfer both open and arthroscopically using the technique described by Pascal below. However, rather than using a single button, we used a double button technique. For the arthroscopic procedures, any residual easily removable metalwork was extracted at the beginning of the procedure. To determine the pre-calculated position for the drill guide, we marked on a spinal needle the distance from the inferior edge of the glenoid. For this case it was 11mm. The spinal needle was then inserted parallel to the prepared anterior glenoid with the tip of the needle at the inferior edge of the glenoid. The predetermined position was then marked on the glenoid using a radiofrequency probe. The drill guide was then inserted and the rest of the procedure undertaken. Post-operatively, the patient's arms are immobilised in a sling for 2 weeks and they underwent a standard stabilisation rehabilitation programme. The patient was assessed pre-operatively at 3 months, 6 months and final follow-up using the Oxford Shoulder Instability Score and the subjective shoulder value. Pre-operatively and at 6 months they underwent a CT scan, and at final follow-up they were also asked to rate their outcome as either excellent, good, satisfied or poor. 10 patients were included in the study and were all available for follow-up. There were 2 female and 8 male patients with a mean age at the time of surgery of 27.3 years and a mean follow-up of 35.2 months. 6 patients had a failed coracoid transfer, 2 patients had a failed Eden-Hibernate, and 2 patients had failed Bankart tears with more than 3 metal anchors present in the anterior inferior glenoid. 5 patients had an arthroscopic Eden-Hibernate, 1 patient had an open Eden-Hibernate with a humeral head osteochondral allograft, 2 patients had an arthroscopic coracoid transfer, and 2 patients had an open coracoid transfer. This is a pre-op x-ray of a patient with a failed coracoid transfer with retained screw shafts, and these are the post-op images after a revision Eden-Hibernate. This patient had a failed Bankart with metal screws and then a failed Eden-Hibernate. They underwent an arthroscopic coracoid transfer. At final follow-up, the average OSIS score had dropped from 25.9 to 5.8, and the SSV had increased from 37.1 to 80. These were both statistically significant. 1 patient had intermittent subluxation of his shoulder, but all of the rest considered their shoulder to be stable. Previously, there have been no specific studies that have focused on the management of retained glenoid metalwork and revision shoulder stabilisation. However, there are several studies that have looked at revision Eden-Hibernate for failed coracoid transfer. Lana et al. Described a series of 34 patients who underwent a screw fixation Eden-Hibernate. They mention removing screws, but give no specific reference to the management of retained metalwork. Recently, Boileau described a series of 7 patients with failed coracoid transfer who underwent a single button revision arthroscopic Eden-Hibernate. 3 of the patients had a single retained screw shaft which was bypassed. However, they did not use any preoperative radiographic planning. In conclusion, guided suture-button fixation of the bone block during revision stabilisation of the shoulder in the presence of significant retained glenoid metalwork provides a satisfying outcome in terms of shoulder stability and function. If you'd like to see more videos of any aspects of shoulder surgery, visit my YouTube channel Cambridge Shoulder or my website cambridgeshoulder.co.uk.